welcome to this week's edition of Sight and Sound Bites from the Eye and Ear Foundation. Today's topic is leveraging the microbiome to alleviate ocular surface disease. I'm Heather Cronus-Danek, Senior Director for Individual Giving for the Eye and Ear Foundation. The Eye and Ear Foundation raises funds for the two world-class departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. The funds raised by the Eye and Ear Foundation help individuals with research and treatment to help people see, hear, and live better. Today's participants from the Department of Ophthalmology are Anthony St. Ledger, Associate Professor of Ophthalmology and Immunology, and he is a PhD. And Hélène Errera, she is an MD, PhD, and she is also an Associate Professor of Ophthalmology. A few housekeeping tips. You will be muted as this is a webinar, not a meeting. Please ask questions in the Q&A section, but refrain from asking personal medical questions. Should you have anything like that that you want answered, please send those to Craig Smith, which is craig@eyeandear.org. So I believe we have Dr. St. Ledger going first. Dr. St. Ledger.
Yep. Hi, everybody. Thank you, Heather and Eye and Ear Foundation, for giving me a chance to talk about our work in the Department of Ophthalmology at Pitt. So, as most people on this call know, that the visual system, like most systems in the body, relies on a series of parts acting in concert to preserve function. So, in terms of the visual system, light passes through the optically clear cornea, focused by the lens, captured by the retina, and processed by the brain. And my lab is primarily focused on the cornea because I like to think, at least in my significant sections, that if light can't pass through the cornea, all these downstream events can't really happen. So my lab is focused on the cornea, which is what I'll be talking about today. And now the diseases of the ocular surface are numerous, and most people know about them or have been afflicted by them. But we know that there are allergies. If you think about ragweed pollen, especially this time of year, your eyes get itchy. There could be chemical burns that you splash in your eye. There's microbial infections like herpes simplex virus or Pseudomonas aeruginosa or Candida albicans. And there's also diseases with no real etiology like dry eye disease and Sjogren's syndrome. And we do know that the current medical treatments for these diseases are relatively effective, but there are some disadvantages with some of these treatments, specifically with lubricants. You know, you have to apply these multiple times a day. It's laborious, it's temporary. It basically treats a symptom and doesn't cure the disease. We have steroids that calm down inflammation at the ocular surface. Those steroids have their own problems because they, one, suppress the immune system, and two, there's a higher risk of glaucoma from using these steroids long term. We know that antivirals and antibiotics are relatively effective at controlling microbial infection, but with the recent concerns over resistance, there are some drawbacks to those as well. Finally, we know corneal transplants. They are one of the most well-accepted grafts in the human body. However, my lab and others have shown that if you do a corneal transplant on a hotbed of nerves infected with virus or other diseases, that those grafts are actually more highly rejected. So the overarching goal in my lab is to understand how we can manipulate the ocular surface immune response, possibly this microbiome response, to alleviate disease. And other topics that we'll briefly address today are: what is the systemic and ocular microbiome? How do we determine which microbes actually matter? What has been done in our laboratory and others to assess a functional role for the microbiome in health and disease? And what have we done specifically to harness the potential of the microbiome? And that last part has been helped by the Eye and Ear Foundation. So these are sort of direct fruits of the funds from the Eye and Ear that we'll get to right towards the end. So now, what is the microbiome? And, you know, it's a hot topic. It's used very frequently in the news today. And if you look up just the general definition of it, the microbiome is a collection of all the microbes, such as bacteria, fungi, and viruses. And so we know that all three of these types of microbes contribute to the microbiome of a human. However, the most extensively characterized is the bacterial microbiome, and that's what really we'll be focusing on today, but know that there are other potential microbes that contribute. We know that there are 10 to 100 trillion microbes associated with each person. It was originally thought that the microbiome constituents outnumber human cells 50 or 100 to 1, but through more rigorous analyses, we now know that the ratio of human cells to bacteria is about 1 to 1 in your body. But still, that's a 50% ratio. So these microbes do matter greatly. And here on the right side of your screen, I'm pointing out sort of the conventional sites that have been assayed for microbes. We know the respiratory tract, the skin, the vaginal tract. We also know the gut and the oral microbiomes are present. And what you'll know that's quite lacking is there's no actual ocular surface microbiome here. And that's because the field of ocular microbiome research is just sort of getting going, and I'll tell you a little bit more about that later. And just some simple things to think about when we think about colonizing microbes. We know that the environment matters. So think about the temperature, think about the amount of mucus that's involved, we can think about the type of nutrients that are involved, as well as the levels of oxygen. We know that the oral microbiome consists of a lot of aerobic bugs. However, when you get deep into the intestinal microbiome consists of a large portion of anaerobic bugs, or bugs that do not like oxygen. So we know that at each one of these sites, there is a very diverse microbiome signature. So now we ask the question, is there an actual ocular microbiome? And this is a question that I asked during my postdoc about 7 or 8 years ago now. And I just have a simple comparison of the two different environments. We have the intestinal, most well-characterized microbiome environment, and then the ocular surface. We know the characteristics of the intestinal environment. Mucus is continually washing through the intestine, washing off the epithelial layer. We know that there are immune cells beneath the epithelial layer sampling those microbes that they're passing by. We know there's high concentrations of antimicrobials, antibodies, and other factors. And we know that there's mucus-producing cells. And what sort of really got me interested in the microbiome, that ocular microbiome, is if we look at the ocular mucosal site, we see very similar characteristics. We see that tears are continually washing over the epithelial layer of the cornea. We know that there are resident immune cells within the cornea. We know there's a more diverse array of immune cells when you get closer to the conjunctiva. We know there's high concentrations of these antimicrobials. And we know the goblet cells populate the conjunctiva, producing that mucus. So that gave us a hint that there's probably microbes here interacting with the host immune system. And the first description of the ocular microbiome came around 2009, where sequencing, so DNA or RNA for bacterial signatures began. And this type of analyses have increased in popularity over time. What's really interesting is that they've quantified the load of microbes at the ocular surface, and we see 150 to 200-fold fewer bacteria per human cell compared to other sites. So this means that the eye is a very low biomass site. Your gut is teeming with bacteria influencing your environment. However, the ocular surface only contains 1 microbe for every 20 epithelial cells. So we call this a very paucibacterial state, a state that doesn't promote a lot of microbes to live. So this suggests that there's an inhospitable environment. But then there was sort of a series of serendipitous findings during my postdoc that sort of catapulted my lab to the microbiome research. We had these mice in our animal facility that lacked an immune factor that controlled bacterial infection. And what we found was that mice lacking these factors actually spontaneously developed bacterial infections of the conjunctiva or the eyelids. So that was one hint that there are bacteria there. When we did our sequencing analyses of the ocular surface, we found that DNA was present. However, this didn't tell us whether any of these microbes were alive, because we know that the half-life of DNA is very long, and it could have been a contaminant, or the bacteria could actually be dead. So then we just ground up a bunch of ocular surface tissue from mice, and we found that this one bacterium grew out. It's called Corynebacterium mastitis. And this was a very serendipitous finding. I can't tell the whole story, but it revolves around me forgetting an agar plate that grows bacteria in a chamber for a week. And that was the only way I could actually find this bug. So thankfully, I forgot about that plate for a week, and that's how sort of spurred all of our studies going forward, was when we found this bacterium. So how do we know which microbes actually matter? So we start by identifying if bacteria actually matter. So we know in bacterial dysbiosis is linked to keratitis and uveitis. Here, some investigators analyze the microbiome signature of healthy eyes compared to eyes with keratitis and see very distinct differences in the microbiome signature. My postdoctoral mentor, Rachel Caspi, found in a seminal study that germ-free mice, or mice treated with antibiotics, actually had the reduced propensity towards uveitis whenever immune cells were activated against the retina. So you can see here there's a lot of disease in this retina. But whenever these specific mice were housed in antibiotic conditions or germ-free conditions, disease was much alleviated. Similarly, if we look at the main antibody that protects the ocular surface, this is secretory IgA. If we compare the IgA in tiers in regularly housed mice to mice that lack all microbes, these are germ-free mice, we see that IgA, a major protective antibody of the ocular surface, is not detectable. So we do know that the bacteria are continually influencing this host immune response to either promote disease in some contexts on the uveitis side, or prevent disease in some contexts in relation to the ocular surface. So while these studies implicate a role for the microbiome, they don't actually identify whether bacteria are relevant, if a single microbe is responsible, or whether these microbes affect physiology. So some studies that implicate a role for the microbiome in ocular disease, in ocular health. We know that immune cells from the intestine can possibly migrate to the ocular surface. We know that soluble factors produced in the gut can regulate inflammation in the eye. We know that gut bacteria can translocate and be deposited at the ocular surface. We know that some local bacteria can stimulate local immunity. And we know that local bacteria can produce soluble factors to regulate inflammation. And I won't go into all these possibilities, but these are just some of the possibilities that could implicate the microbiome for ocular health. But we focus on this one microbe called Corynebacterium mastitis. And I'm not going to go into the complex immunological mechanisms, but we do know that this microbe colonizes the conjunctiva, and through a series of downstream immune responses, protects the ocular surface from infection. You can see here that whenever we have mice that are not colonized with CMAST and challenge them with the fungus Candida albicans, we see a certain level of fungi, and we can see it sort of infiltrate in the cornea here. However, if we colonize mice with CMAST and challenge them with the same amount of fungi, we see a dramatic reduction in the amount of fungi that can infect the eye. And you can see here that the eye looks much better. Similarly, or further, we see that what happens if we disrupt the microbiome with topical antibiotics. So basically, we took CMAST colonized mice and treated them with tobramycin, a commonly prescribed antibiotic for Pseudomonas aeruginosa infection. And then we assessed whether the ocular surface immunity was affected. And you could see here our treatment regimen, that if we take mice immediately after antibiotics, we see no detectable CMAST. Even 1 to 3 weeks after ceasing the antibiotics, we don't see those CMAST coming back. However, by 4 weeks, we see CMAST is back. And so we asked the question, are these CMAST microbes here, are they now resistant to tobramycin? And as it turned out, they're not. It's basically just, this is an incomplete disruption of the microbiome. And after 4 weeks, we get a reestablishment of CMAST colonizing the eye. And if we challenge these mice with a blinding pathogen, Pseudomonas aeruginosa, We see that if mice are not colonized with CMAST, we see a very high level of bacterial burden. But if they're colonized with CMAST or they recover CMAST, you see significant reductions in CFU burden. However, during antibiotic treatment, Pseudomonas is similar to the non-CMAST control. So this tells us that antibiotics are disrupting the immune response to the point where the eye is more likely to be infected by a blinding pathogen. However, I need to mention that there is a disclaimer here that antibiotics are a good thing. We're just suggesting possibly a more judicious approach towards using them. So it's just something to consider in the future as we pursue our studies. We also know that CMAST can be relevant to humans. We see that CMAST stimulates immune cells from the humans. And we also see that Corynebacterium, the genus, is present in microbiome studies. So suggesting that Corynebacteria are a core component of the microbiome. So finally, to close out my part of the talk, how do we engineer eye colonizing bacteria to possibly act as a long-term delivery system, or probiotics is my normal dad joke in this part of the talk. Basically, we know that CMAST can colonize the eye long-term, so it can remain at the ocular surface. We ask the question, can we genetically modify CMAST to produce immune regulatory cytokines or produce factors that create more efficient tears to alleviate ocular surface disease? So we're talking about engineering the eye colonizing microbe to alleviate this ocular surface disease. And this is one of our Hillman Challenge Grant awards. We've used funds from that for this study. And so we chose IL-10, interleukin-10, because we know that interleukin-10 not only suppresses inflammation, so suppresses disease, but also enhances wound healing. So increases the speed at which a wound would heal. So we used IL-10 and we used a wound healing model of disease here. And so when we created this genetically engineered bacterium, we wanted to make sure that it produces IL-10, right? Because if it doesn't produce it, it's pretty much useless to us. So you can see here we have 3 candidates that produce levels of IL-10 significantly more than our unmanipulated control. So this suggested that IL-10 is produced and is detectable. We then asked the important question, can our genetically engineered microbe still colonize the eye? And we see that it colonizes just the same as the wild type mouse, as the wild type bacterium. Finally, this is the most important experiment here, is if we colonize mice with PBS or wild type CMAST, we see sort of this linear progression of healing. However, if we colonize them with our IL-10 producing bacteria, we see a 50% increase in the speed that a wound heals, suggesting that these microbes are actually speeding up wound healing and helping disease. We've neutralized IL-10 in these mice too and show that the speed is abrogated, suggesting this is a direct effect of IL-10 and not from some peripheral effect we haven't thought of yet. So with that, I will close, but I wanted to go over that we know that the microbiome does influence ocular surface disease. We also know that it influences intraocular disease, which Dr. Errera will talk about in a bit. Our laboratory is active in using mouse models to identify causal relationships between bacteria and physiology. This is because humans aren't really willing to give up their eyes for these types of research, which is understandable. So we use mice to make suggestions that we try to confirm in humans. We've engineered an eye colonizing microbe to secrete a factor to enhance wound healing. And we're currently pursuing standards that allow us to, in future generations, to effectively study the human microbiome. With that, I'd like to thank all the people in my laboratory. We have other projects focused on ocular surface innervation, but this today was focused just on the microbiome. We have multiple grants through the NIH, but we also have a lot of support financially and emotionally through the Eye and Ear Foundation, which I would like to thank. And with that, I can stop, and I believe we will answer questions afterwards. So I will pass it over to Dr. Errera.
So thank you for the nice invitation to talk about uveitis. I'm going to talk about uveitis, which means inflammation of the eye. I'm going to talk to you, like Dr. Saint-Léger say, about uveitis, which is an inflammation of the eye. It can affect, just to explain exactly what we mean by uveitis. It can affect the front of the eye, so the cornea, the aqueous fluid in the front, and the iris. It's the anterior uveitis. It can affect the middle of the eye. It's called intermediate uveitis, and one other form is called pars planitis, because as you can see with the arrow here, the pars plana is at this edge of the retina. We are in the back of the eye, and it's still part of intermediate uveitis. Intermediate uveitis is an inflammation of the vitreous, the gel into the eye. And we have the posterior uveitis. It's the back of the eye, retina, choroid behind, optic nerve being inflamed. My work as an ophthalmologist is mainly to detect, diagnose, treat uveitis, all those type of uveitis, and the retina as well. So how do we diagnose in the clinic uveitis? We use the slit lamps, and we have a light, and we can look at the cornea. And when we see those deposits, we call them keratic precipitates. There are inflammatory deposits that you can see here on the just inferior. They are behind the cornea, and they are full of inflammatory cells, mainly macrophages and epithelioid cells. That's the name of those inflammatory cells. You see that the uveitis completely damaged the iris, and the pupil is not round shape anymore. And then here is just a drawing of what we see, those precipitates that we see in real life here. Sometimes the precipitates, they are very small, like here and here. And obviously, just looking at the eye, we can try to find out what the patient has this uveitis, which type of uveitis, what is the cause, to better treat the patient. So a few pictures of intermediate uveitis when we see an inflammation into the vitreous. As you can see in A, in the left, we hardly can see anything in the back of the eye. We just see, like through a fog, the optic nerve, which is here, yellow, and a lot of inflammatory cells into this vitreous. That's why the vision is blurry. And on the top right, you see a normal retina, so you can really compare. And on the right here in B, you see a patient with pars planitis with an inflammation inferior. It looks like fog as well, and it impairs the vision. So the different diagnoses to consider, it can be idiopathic, mean that we never find the cause of the uveitis. GIA, very frequent in children. HLA-B27. HLA-B27, it's a protein on white blood cells that can cause immune system dysfunction, and can cause autoimmune disease as well. Spondylarthropathy, sometimes some types of arthritis, inflammatory bowel disease, psoriatic arthropathy, rheumatoid arthritis, infections, herpes virus, cytomegalovirus, zoster, toxoplasmosis, Lyme, syphilis, HIV. There are millions of infections that can affect the eye. TNU, it's an inflammation of the kidney and the eye. Sarcoidosis, and it's just few diagnoses. There are many, many more to consider. There's things that I just thought when you asked me to talk about uveitis, I could share a few pictures of patients with different types of uveitis. So you see how wide the types of uveitis is, and how many types we can see. So sarcoidosis, it's an inflammation that can of the eye, but it can affect the lung. The skin, the joints, the lymph nodes is still a mystery. We still don't know what is this inflammation. We think it's not infectious because we don't need antibiotics to treat those patients, only immunosuppressive treatment and steroids. And then I wanted to show you what it looks like when a patient has an anterior uveitis related to sarcoidosis. You see the inflammatory cells, the precipitates behind the cornea, large, white, it makes a blurriness in the vision. The iris gets distorted. And then we see an inflammation of the lungs as well that we can detect on the chest X-ray. Other manifestations of sarcoidosis, they can create nodules, inflammatory masses on the conjunctiva here. They get very red and painful. It can affect the lacrimal gland, and it can affect the retina. And we see what we call choroiditis, an inflammation of the retina and the choroid. And it looks really white and yellow, that all those small spots that you see inferior to the retina. Other type of inflammation among the wide group of intermediate uveitis affecting the vitreous, we find the pars planitis when it just affects the edge of the retina, and with plenty of inflammatory cells here. They look like snowballs. That's why we call them snowballs. And there are some, without any systemic disease or associated infection, only the eye gets inflamed. And many complications can affect the patient because of this inflammation, cataract, macular edema, vitreous haze means a lot of fog in the vitreous, high pressure. It can make the patient blind if the pressure is out of control. Retinoschisis, or retinal detachment, and epiretinal membrane, it's the wrinkles on the surface of the retina. So how does a macular edema looks like? It's here, the retina, the macula in the center of the retina is really swollen, and you can compare with a normal retina in B. And the vision gets very blurry, especially to read, because the macula is in the center of the retina. It's a reading vision. And when we do an angiogram of the eye, of the retina, we see that it's really swollen. It appears white. Another cause of uveitis called uveitis related to HLA-B27. It's the protein I talked to you about that can cause immune system abnormalities and autoimmune disease. And this disease is really painful. It affects the front of the eye. It's an anterior uveitis. The eye gets very red and painful. The cornea can get a little bit edematous, so not clear anymore. And you see on the arrows that the iris is attached to the lens behind. We see it's like glue or some attachment. It can impair the vision, and it can be associated to ankylosing spondylitis, which is a type of arthritis. When we consider the inflammation, the uveitis that we see in children, most of them are related to the disease called JIA, juvenile idiopathic arthritis. It's an autoimmune disease. Very often we see uveitis related to this disease. It can give a chronic uveitis. That means that it lasts longer than 3 months if untreated. And those patients, they need long-term treatment most of the time. Can lead to glaucoma and cataract. And when the uveitis has been active for a long time, we see a calcium deposit on the surface of the cornea, and the cornea gets white. And of course, it affects the vision. We have treatment for all of those. Another type of uveitis, I just saw one patient in the clinic this morning, and she was asking me, is it frequent to have a birdshot chorioretinopathy? I told her it's very rare, but the uveitis clinic are full of patients with birdshot, so we know how to treat it with immunosuppressive treatment on long term. It affects the retina, but not only the retina, the choroid behind the retina as well. And we see it because it's difficult to see on the fundus pictures like here. And when we look at the patients, we see sometimes the vitreous haze, so cells in the vitreous. But then when we do an angiogram, we see better the inflammation of the retinal vessels. And you see them with the arrow. The optic nerve is inflamed as well. So why do I say it's inflamed? It's because we see the dye is leaking from the vein, and then the veins, they appear a little bit blurry here and here. So everywhere where it's blurry, it's an inflammation of the vein. And then when we do another type of angiography is called ICG. With a green dye, we see the choroid, and then we see millions of small dots on the choroid, and those are nodules, inflammatory nodules. And on long term, it can really affect the vision. Other types of posterior uveitis, inflammation in the back of the eye. It's a multifocal choroiditis here. On the left, that choroiditis. On the right, it's a normal retina. And we see many pigmented scars where the inflammation has affected the retina and the choroid behind, and all around the optic nerve as well. And obviously, it can affect the vision because it can damage the cells of the retina. Another type of posterior uveitis, very rare in United States, very frequent in Japan and China. It's a Vokoyanagi harada. It's an inflammation of the retina and the choroid, and it looks like bubbles on the retina. When you look at the retina, there is a big bubble here, a big bubble here, and many bubbles around the optic nerve in both eyes. It's always bilateral. It creates this, we call them the retinal detachment because of the inflammation of the choroid behind. It makes the vision very blurry. It's a normal eye, just for you to compare with the eye with the bubbles underneath the retina. And when we do an OCT scan, it's a scan to look at the profile view of the retina. That's a normal retina, really flat. And here we see the retina is detached with the fluid underneath. And of course, the vision is very blurry. We have good treatment as well. And I talk about autoimmune disease, about uveitis with no obvious cause or autoimmune. Here, let's move to the infections. And it's a patient with an infection of the retina caused by a virus, cytomegalovirus. When it affects the retina, usually it's there are patients immunosuppressed. They are on treatment that makes them less likely to fight infections, like immunosuppressive treatment after graft transplant, kidney transplant, or people who are immunosuppressed because they have HIV. And they can be affected by this virus in the back of the eye. This virus can affect the front of the eye and give a lot of floaters and a very blurry vision, even if the patient are not immunosuppressed, if they are immunocompetent, if they have no other disease. That can affect as well the front of their eye. And here you see a bleeding on the retina, and here you see the direct inflammation of the retina. It's called a retinitis by the virus. So why I show you all those different types of uveitis, infectious, non-infectious, is just because with Dr. Sandliger and with the Microbiome Center from the University of Pittsburgh, we are starting, and now we are very close to start this study. We are going to start a study with patients with uveitis. And the first part of this research, it took a long time, was to get approval by the ethics committee to take sample for the blood, but to take sample from the eye as well. So it took some time. And then now finally we have been approved, and we're going to start soon. We will choose many different types of uveitis among our patients from the clinic. And we will identify if microbial and lifestyle exposure associated with the disease. We will evaluate the gut microbiome during follow-up at baseline and on treatment to see if there is any change. The treatment usually are steroids or immunosuppressive treatment for the patient with non-infectious uveitis, and it can be an antiviral treatment with a patient with viral infection. Participant with these different types of uveitis will be asked to provide a stool for microbiome, stool sample, and aqueous fluid and blood sample. So how do we do in the clinic? We take a little bit of the aqueous fluid that just behind the corner. It's not painful at all. We put drops and no one feel anything. And we use, because we use a very fine needle, and we send it to Dr. Saint-Léger to test for cytokines, the immune protein, to try to understand which type of inflammation is in the eye. And we will complete this study with a diet questionnaire, psychological and medication questionnaire. If the patient is on antibiotics, it can have an impact on the result of the microbiome test. And we will identify if there is a gut microbiome, taxonomic and or functional signature at baseline associated with inflammation. So we will try to identify microbiome association with the cytokines, uveitis treatment, lifestyle, diet, smoking, etc., and circulating hormone levels from the blood. And we will see if it's associated with uveitis recurrence. And it's just to show you the cytokines. So we talk about cytokines when during the COVID time pandemic, there was a cytokine storm with all those protein involved in the inflammation and the immune system. And then it's just to show you the study. Will took the samples at different time points. Microbiome cytokines will be analyzed in the aqueous fluid and in the blood. And we will test the hormones in the blood as well. So the aim of the study is obviously to find out which type of microbiome is involved in different types of uveitis, but to see if we can adjust and modify the treatment. We talk about probiotics, dietary change, antibiotics intervention depending on the microbiome. So that's the goal of this study. Thank you very much.
Dr. Errera, Dr. St. Ledger, thank you so much. We have quite a few questions. Some of them do touch on points that you've touched on briefly, but we will have a little time to flesh them out a bit more. So let me start. Are there any probiotics for the microbiome of the eye?
Not yet. And I think that's probably because we don't know what technically is a good bacterium or bad bacterium at the ocular surface. So there is a new NIH-sponsored consortium looking into defining what the core microbiome is. And then I would imagine in the next few years, we figure out what's explicitly healthy and not, and then go from there.
And the study we're going to start will be just to identify which microbiome, and if the current treatment for uveitis influences the microbiome that we find. And then it will be another study when we'll identify which uveitis, which microbiome. It will be an interventional study is to start treatment based on the microbiome. It will be the second phase of the study, I think.
Thank you. What new developments in the study of ocular microbiomes are on the horizon? Can we expect any new recommendations or therapies?
Yeah, so, I think we're trying to assign function to bacteria as it stands right now. So a lot of the problems with current microbiome studies are correlative. Basically, if this bacteria is present and you get this disease, then they must be linked. But my lab for the ocular surface microbiome is to identify what specifically these bacteria are doing and whether it's a good or a possibly bad thing. In the gut, we do know that things like butyrate are produced and they sort of regulate inflammation. So systemically, there are studies looking at possibly butyrate and other secretive factors that could suppress ocular inflammation.
Okay. Does the microbiome have an impact on dry eye?
So that is, I think that's a good question, and we're beginning to understand, yes, it does. But how it impacts dry eye, whether if you lose a bacterium and you're more likely to get dry eye, or you gain a bacterium and you get dry eye, we're still not sure, but it does influence the progression of dry eye for sure.
And we know that in dry eye, there is a big component of inflammation. So, and we use immunosuppressive treatment, topical, to treat dry eyes as well. So everything is intricated.
Well, on that note, you had mentioned Sjogren's disease earlier, and that's one of the big factors in Sjogren's, dry eye, dry skin. What happens in situations such as that? I mean, how do you treat? What are you looking for?
So we treat the dry eyes, and we treat the inflammation as well. So when we treat dry eyes, we use serum drops. We use tears for the eye, lubricating ointments. And we treat the dry eyes with cyclosporin drops, with immunosuppressive treatment. And we can even go to systemic immunosuppressive treatment. That we contact the rheumatologist and they start the patient sometimes on immunosuppressive treatment, systemic immunosuppressive treatment.
Systemic. Thank you. Okay. What is the best way to have healthy microbiome in our eyes?
That is a great question. And I think it's just probably currently the best I could say is living a healthy lifestyle, right? And trying not to put too many things in your eyes to disrupt the microbiome at this point.
And in uveitis, we always compare uveitis treatment, uveitis disease to systemic autoimmune disease, because it's most of the time uveitis is autoimmune. And we know that there is a healthy diet for autoimmune disease. Usually it's a Mediterranean diet. That's what the rheumatologists recommend. So fruit, vegetables, olive oil. And there is no real study on uveitis and diet. There have been studies on mice with uveitis. And then they say that pectin that we find apple in pear is good for the eye, but it's in mice. So we don't know for the eye. So always tell the patient, we don't know. Take a Mediterranean diet, but with the study we're going to start, there will be a diet questionnaire. And then we'll understand why sometimes a patient in the clinic, they say, oh, I have a relapse of uveitis and I changed my diet. Is it related? And so we don't know. So we'll know with the study, hopefully.
It's interesting to see how that'll play out as you get more information from the patients. How do you investigate idiopathic uveitis when you have a patient come to see you?
Oh, we have, so there are guidelines which tests to do. So we have basic tests. We look for the kidney function, the liver function, because there are these systemic diseases that can affect kidney, liver. We look at a molecule called CRP in the blood to see if there is a systemic inflammation. And then we, depending on how the uveitis looks like, that's why I was showing you the precipitates, the shape of them. We ask different sarcoidoses, HLA-B27, because they don't look the same in the clinically, this disease. So we can add those tests and we ask questions, because if the patient, like this morning, the patient told me, oh, I was bitten by a tick recently, and then they have an inflammation in the eye. So there are uveitis related to tick bite. So we ask many questions if they have pain in the joints, because we can find rheumatoid arthritis. We can find GIA, juvenile arthritis in children. So we ask many questions. And then usually when we have a suspicion, we refer to rheumatology if we think it's autoimmune or rhematologic. Sjogren's disease, we ask for dry mouth, for dry eyes. And then because Sjogren's disease can be seen in sarcoidosis, in lupus, in other disease. And then if we think it's an infection, herpes infection, we start the treatment, but we are looking to ask the infectious disease specialists their opinion. So we really work as a team. We have a combined clinic with rheumatology here. uveitis rheumatology clinic once a month when we see the patient together when they are complex for the treatment, but for the diagnosis as well.
Oh, I did not know that. That's very interesting.
Dr. Andrea Coca is a rheumatologist who has a special interest, one of the rheumatologists with a special interest in the eye, because there are many of them.
Issues with them. Okay, do patients commonly experience side effects from being immunosuppressed?
So I think it's a question for me as well. They can, yes, this morning, it's always this because it's this morning a patient was on Cellcept. It's a mycophenolate mofetil, it's an immunosuppressive treatment, and she told me that she doesn't tolerate it because she has a GI, a gastrointestinal side effect. And then I told her, I'm going to contact rheumatology because there is another mycophenolate mofetil molecule that it's a coated pill, I think they say, and then it's not painful for the stomach at all. So the patient can have side effect, but we can switch for the medication depending what is the side effect. And that's why we do regular blood tests every 3 months usually, just to detect sometimes a side effect on the kidney or on the liver before it creates any damage. That's the main side effect that we see. It puts the patient immune system down. So a patient on immunosuppressive treatment needs to rush to see the family doctor if any sign of infection, fever, to be started on antibiotics a little bit earlier than other people. And then we're always anxious about on immunosuppressive treatment about the risk of cancer, malignancy. So patient needs to see their family doctor every year to check if no melanoma on the skin. And then not to worry too much because we keep patient on average for 2 years on those immunosuppressive treatment. And we see usually a risk of cancer when it's forever after a transplant or a graft. For people, we need to keep it for 20 or 30 years. It's rarely the case in uveitis.
Well, one of the things I didn't mention, and I found out last week, is that you are actually a pharmacist.
Oh,
You
yeah.
were, yeah. So that leans into your pharmaceutical background and your training, you know, switching up the medications.
That's why I've got this special interest in the medications, and that's why the research I'm doing is always toward the medications.
It makes a lot of sense when you put the pieces together.
Yeah.
How common is uveitis?
I can't remember how common it is in the general population, but it's quite common. I can't remember. I can't answer this question. Sorry, I don't know. I don't remember the prevalence in the population. Do you know, Dr. Sandleger, by any chance?
I don't.
No, it was more frequent. We think it was more frequent during COVID. Because COVID was creating fewer uveitis thing. We see perhaps more uveitis as well recently because there are new medication, chemotherapy that we use for people with cancer that create uveitis. They save life, create uveitis. We treat the uveitis, no issue. So we see more uveitis perhaps than before, but I can't tell how frequent it is.
Okay. And finally, do certain external environmental factors play a role in the microbiome?
Yeah, so I think contacts definitely do. It's probably the most prevalent one. They see pretty distinct microbiome signatures with contact lenses and non-contact lens wearers. People with allergies allergies can cause alterations in it. But then we get in the question of what came first, the alterations of the microbiome and then the allergies, or the other way around. So environmental factors do influence it. We're just trying to figure out how they influence it.
Well, that is it for our questions. Thank you both so much for joining us today. We will be back in 2 weeks with a webinar, and I believe it is on salivary stones from otolaryngology. But to all of you, have a great day, happy Friday, and thank you for tuning in. Bye-bye.